It's true that the private sector does play a large role in many places in maternal health. One thing that we're going to be talking about here is that unlike most of the other healthcare that's provided in maternity care in Uttar Pradesh, the public sector is really dominating. So let me take a little bit of a step back and speak a little bit to this point that Dean was talking about earlier, which is that early life health and maternal and child health have actually a lot to do with public finance. We know that things that happen to a mother when she's pregnant have impacts on a baby. And things that happen to a baby within the first couple years can influence a child's cognitive development and then later on his or her economic productivity as a worker. So early life health has lifelong consequences, and it's an important thing for almost any sort of policy thinker to be thinking about. And it's an important topic in particular in India because we know that early life health in India is worse than what the economic indicators would predict. Not only India having high neonatal mortality and poor health statistics, but it's even worse than what you would think based on GDP per capita, or in this case, fraction poor. So I've just done a very simple comparison of a few countries looking at the neonatal mortality rate. So that's the fraction of babies who are born alive. So they're born, they take a breath, and then they die in the first month of life. And it's usually given in per thousand terms. So that 32 would be 32 per thousand babies who are born alive dying in the first month of life. And as we see that fraction is higher in India than in these other countries, despite the fact that India has fewer poor people. And I could have done this with a number of other health indicators or a number of other economic indicators. But I wanted to sort of have a way to start talking about neonatal mortality, since that's going to be sort of a big health indicator that we'll look at in this presentation. Okay, and perhaps it seems obvious for those of you who know about population statistics in India, but it really is the case that improving health in Uttar Pradesh is essential to improving health in India. You may be aware that about 1 in 5 births everywhere in India takes place in Uttar Pradesh, and it's about 1 in 3 neonatal deaths and 1 in 3 maternal deaths. So a disproportionate share of poor early life health occurring in Uttar Pradesh. And there's a little bit of an asterisk here on this neonatal death figure. We're going to come back and revisit these figures because I think that they're not as credible or not as well understood as maybe the reports make them out to seem. Now let me get to the hospital part of this. It's true that Uttar Pradesh has many of the same early life health policies and programs as other parts of the country. It has the ICDS. Let's see, what else does it? There are a couple of districts that are trying out maternity entitlements. It has the A&M program to get children vaccinations in Uttar Pradesh. But the one program that actually has been being implemented and being implemented in a big way in UP in the last 10 years is the Janani Suraksha Yojana. So this is the cash transfer to incentivize hospital births. And I'll show you some data from the NFHS in a minute that suggests that this has really been a big policy tool, and people really are increasingly giving birth in public hospitals in particular. And just for those of you who are unfamiliar with the program, the program gives 1,400 rupees to women from rural areas who give birth in public hospitals and about 1,000 rupees to women from urban areas. There have been a couple of tiny experiments with incentivizing birth in private facilities, but by and large, that really hasn't been part of the program in UP. Okay, so then let's take a look at some of the data. So the next several slides that you're going to see, or I guess all of the ones that have these lines on them, are from the NFHS. So we, at this point, have NFHS for summary statistics sheets, so state level summary statistics and national level summary statistics. So I played around with those, and you can take a look at sort of India without Uttar Pradesh and then Uttar Pradesh. And we see this just rapid increase in the fraction of births that are happening in hospitals. And it's been big across India, about doubled in 10 years, but in Uttar Pradesh, it's more than tripled. So a really, really huge increase. And if we were to get more updated data, so the way that the fact sheets from the NFHS publish these statistics is an average over births in the 5 years before the survey. So that's the 2010 to 2015. If we were to get, say, 2017 data, I'm sure it would be even higher. And this has really been happening in public hospitals more than private facilities. There has been an increase in private facility birth in the rest of India and in Uttar Pradesh, but the big increases have been getting people to deliver in public hospitals. And so in Uttar Pradesh, we went from a situation where like 6 or 7% of births were happening in public hospitals to, my guess would be it would be about a half, perhaps even more if we had 2017 data. So this program has been happening in a really big way. We surprisingly have a program that is getting people to change their behavior and doing something different. In Uttar Pradesh, we might really want to know the answer to the question of whether this rapid increase in birth in public hospitals has resulted in better health. That is presumably the point of the program. Now, neonatal mortality would be a really good place to start in terms of evaluating whether JSY has an impact on health. It would be more useful than infant mortality because infant mortality encompasses death between birth and the first year of life, and so that includes the neonatal period and the postneonatal period, where the causes of postneonatal death are quite different from the causes of neonatal death. Postneonatal death might be more about diarrheal infections, about pneumonia. Neonatal death would be things that happen pretty early within the first days and weeks of life. And most neonatal death happens in the first couple days, and that's exactly the time when the woman is in the hospital. So presumably hospital staff could intervene if there were some sort of problem in the neonatal period. So, we expect that JSY would be responding to things happening early, and that neonatal mortality would be sensitive to that. Now, all of that is a long preamble to say, I really wish I could show you data on neonatal mortality from Uttar Pradesh. Perhaps it's a little surprising to you that a state of 200 million people and probably about a third of the neonatal deaths in India doesn't have credible statistics on this. So I'm going to try to back up that claim and tell you a little bit about what's been going on with that. So, you may see some reports that have neonatal mortality numbers in UP, but if you dig into the data, you'd find that two different government sources make very different claims about levels and trends of neonatal mortality in Uttar Pradesh. And unfortunately, the NFHS has not yet published the neonatal mortality figures. So we have the infant mortality figures, which I'll show you in a little bit, but we don't have the neonatal mortality figures. And if we did, it would be from 2010 to 2015, which at this point would be a little bit old. And I just want to point out that knowing what this number is really matters. It matters whether it's 45 or 50 or 55. So the data that I showed you earlier was from the annual health survey. That put the 2010 neonatal mortality rate at 49 per thousand. And that would mean that 1 in 3 neonatal deaths happen in India. I showed you that one before. It would also mean that if UP were its own country in 2010, it would have had the third highest neonatal mortality rate in the world. Only Angola and Pakistan would have had higher neonatal mortality rates. And if you sort of think about moving that forward, it doesn't really change Uttar Pradesh's ranking in terms of world NNM. Okay. And then, from a public finance perspective, this is a pretty important piece of information to have because, as I was saying, presumably the JSY is supposed to be reducing neonatal mortality. It's 5% of the National Health Mission budget, JSY, in 2016, 2017, and we don't have a credible measure for the outcome. Okay, so with a long preamble, let me walk you through sort of the best I can data in the last 15 years on neonatal mortality in Uttar Pradesh. So you'll notice that the time series that we have is from the sample registration system. And the sample registration system is collected from a representative set of villages and census blocks in urban areas. So, if India were to have a complete vital statistics system, every single birth and death would be tracked and monitored by the government. That's not the case. It was, a really good plan. Got started, I think back in, we have good data from at least the 70s, although I think there were efforts at this before this, looking at neonatal mortality, postneonatal mortality, infant mortality, fertility rates, death rates, all sorts of great vital statistics data from this set of sample villages and sample places in urban areas. Now, you can see that if we compare NFHS data from around 2003 to the SRS, things match pretty well for Uttar Pradesh. As time goes on, the SRS starts documenting a steep decline in neonatal mortality in Uttar Pradesh. And that is quite different from what the annual health survey found. So the annual health survey was this very large-scale survey that was representative of 9 states. It was done as a panel, actually, between 2007 and 2011. For those of you guys who know the annual health survey, these are not the same numbers as come out on the report, so the reference periods are slightly different than the report years. That'll be that difference if you know the AHS. And for successive waves of the AHS, there started to be a bigger and bigger difference between the SRS and the AHS. It was about 7 per 1,000 by the last AHS survey. And then, as I was saying, the NFHS hasn't released these statistics, so there were big question marks on what it could be for 2013, which would be sort of the approximate reference year for the NFHS 4. And so, I put those markers in the place that I did basically by saying if neonatal mortality were the same fraction of infant mortality in 2013 as it was in 2003, what would neonatal mortality be? Around 41. And then if you projected the NFHS trend, again, made up NFHS trend forward, be about 39. And even that would be a huge divergence from the SRS. I think it's probably a little bit of an underestimate because there's some evidence that in other parts of India, as time goes on, neonatal mortality becomes a more important part of infant mortality than it has been. So this is, again, the NFHS data. The NFHS 4 puts the infant mortality for Uttar Pradesh now at 64 deaths per 1,000. And that's a slower decline than what we were seeing in the rest of India, down from 53 to 35. So we see faster increases in hospital births, slower decreases in infant mortality. And now you may be thinking, okay, maybe this sort of faster decline in the rest of India is being driven by southern states, states with better governance, states with better health systems. It turns out that is not the case. So these are, again, the high focus states that the AHS went to, although it's NFHS data. And they're sort of considered states that have poorer health systems and poorer governance. And what we see is that Uttar Pradesh continues to lead in terms of infant mortality, and it's had the lowest decline in the last 10 years, which is a bit surprising because a state that starts the highest, you expect it to have a greater decline. States like Assam, Madhya Pradesh, twice the decline in infant mortality that Uttar Pradesh had. It's really been very slow. So this trend suggests that hospital births in UP have not been doing as much to improve health as we might like. There are a few other studies that I'd be happy to talk about in the questions that use data from across India to try to understand the impact of JSY and neonatal mortality across India. They don't find particularly promising results. And so what we're going to do for the rest of this presentation is draw on several years of both qualitative and quantitative research in public maternity hospitals in Uttar Pradesh to try to provide some ideas about why not. Research question's pretty simple. What happens to people who go to public maternity hospitals in Uttar Pradesh? Why hasn't this rapid increase in births resulted in better improvements in maternal and infant health? So we'll draw on data collected over a period of 5 years. Primarily, the data are coming from Sitapur district and from Lucknow district, but we've also done some observations in Ambedkar Nagar, Faizabad, and Barabanki, which are not so far from Lucknow. And so a brief overview of why the hospitals don't seem to be improving health very much. Perhaps promoting hospital birth doesn't actually prevent the most important cause of neonatal death. So we're going to take a look at some statistics about prematurity and low birth weight. And unless you can sort of treat the symptoms once the baby is born, the hospital isn't going to do a lot for a low birth weight baby. And we'll talk a little bit about sort of more recent efforts to provide better hospital care to low birth weight infants, but that's not going particularly well. And then, some of the other causes of death that a hospital might be able to take care of, things like birth asphyxia. Hospitals are providing extremely poor quality of delivery and postpartum care. So, not really seeing a lot of evidence that they're doing a great job saving babies at birth. And then because prematurity and low birth weight is such a big part of this story, it's important to think about whether hospitals are doing anything for these vulnerable low birth weight newborns. Unfortunately, they're doing very little, and there's almost no counseling to improve care once the children get home, which would be a really essential part of what a hospital should be delivering to the parents. So let's take a look at, this is sort of the main chart from, at least on neonatal mortality, from something called the Million Deaths Study. So this is a wonderful study. It's based on a sample from the sample registration system. And even though I've talked about how I think the SRS neonatal mortality numbers in UP may not be correct, I think the broad story that this study is telling from across India is likely to be quite right on. And so what they've been documenting is cause of death between 2000 and 2015. And so there has been, thankfully across India, a strong decline in neonatal mortality. And the biggest declines are coming from birth asphyxia, they're coming from neonatal infection, and from some of the other causes. Unfortunately, prematurity and low birth weight has not been declining by very much. And as you can see, increasingly it's a larger and larger share of neonatal mortality. They haven't published statewide statistics, but I would suspect that it's an even higher share in Uttar Pradesh. So these data are meant to highlight the point that although this was national data, I have some data on normal deliveries or vaginal deliveries in Sitapur district, and a very, very large fraction of infants who are born in this public hospital are low birth weight. So 2.5 kilograms is considered low birth weight, and we found that about 42% of vaginal deliveries were low birth weight, and that the median baby was just 80 grams above the low birth weight cutoff. So hospitals have a huge number of infants that if they were going to be providing the sort of care that the guidelines intend them to provide, they would be providing it to an awful lot of kids. And sometimes when I give presentations about health in India, people sort of scratch their heads and they wonder, well, are Indians just genetically smaller? So do some research on height. There's questions about whether Indians are genetically shorter. They're not. But just to sort of stave off those sorts of questions, I've put up some comparison data to Indians in the UK. So this was a study that's representative of England and Wales from 2005, a much smaller fraction of Indians in the UK have low birth weight babies, and the mean birth weight is about 0.5 kilogram larger. So, this has to do with the environment that the mothers and pregnant women are living in rather than anything to do with genetic differences. And sort of a fascinating, very short study. I wanted to ask them so many more questions. Infants in a rural Tamil Nadu hospital in Vellore district found a pretty similar fraction of low birth weight to the UK. So, it is possible to achieve better maternal health within India. Uttar Pradesh just hasn't done it yet. And so, what's really a driving force here, there are many causes of birth weight and low birth weight and prematurity, but a really, really important one is poor maternal nutrition. It's widespread in Uttar Pradesh and in India, and getting a woman who's been, malnourished for most of her life and then 9 months of pregnancy to deliver in a hospital, unless that hospital is really well equipped to treat low birth weight babies and to teach parents care for low birth weight babies, there's not going to be an awful lot that they can do to save that child at birth. That said, there are other causes of death, and they could be doing something for low birth weight babies. So let's talk a little bit about the poor quality of care that mothers and babies are getting. So, we documented a large number of negligent and dangerous practices. I've sort of put some of the least medicalized ones here. Very frequently observed newborns simply left unattended. So, baby's delivered, it gets put in a metal pan. Sometimes they cover it over with a cloth. What you're supposed to do when a newborn is delivered is watch it, make sure it's breathing, see if it needs to be suctioned. It's supposed to also be given pretty quickly to the mother for skin-to-skin contact. That is going to stabilize the baby's temperature, prevent hypothermia. That is something that's not being done, and the hospitals aren't really set up to do it. So you see in the government guidelines, okay, there are these things that you're supposed to do when a baby is born. Some of them the hospital could do and are not doing. Some of them the hospital is not really set up for, like the skin-to-skin contact, but nobody's really asking that question. And really, really importantly, there's no checking of the newborn's weight or the newborn's temperature. In some places, nurses do write down a birth weight, but it's always sort of guessed and eyeballed, and the significance of it is never explained to the parent. So, all of the babies, and I think increasingly, this is anecdotal, but increasingly we've seen babies made up birth weights above 2.5 kilograms after the SNCUs, the special neonatal care units, came into the hospitals. They supposedly had to, although they didn't, admit babies below a certain birth weight. So now none of the babies were at that birth weight. It was a data nightmare. I would not recommend analyzing administrative data from UP hospitals. In terms of other aspects of poor quality of care, almost everybody knows that you're supposed to have initiation of breastfeeding right away. It would be great if hospitals would counsel people. This very often involves yelling at the patients if it's done at all. There's a real lack of doctors and nurses in the wards at all. And then these places are really crowded. So you guys saw the huge increases in use of public facilities. And this is not at the CHCs or the PHCs. It's in just a few select hospitals. And you've got the father is there, the father-in-law, the mother-in-law, the woman's other children. These are very, very busy places. They lack any sort of privacy for breastfeeding. And so the effect is that babies are breastfed very little in their first few days of life. If they're given anything, it's often these syrups and tonics or cow or goat milk, which is not a good way to start to initiate breastfeeding. There's just tons and tons of abuse of patients. So, a particular thing that women are abused for is for having multiple children. Lots of physical abuse of women, hitting them while they're delivering babies. And then unfortunately, we observed a lot of this. It would be great if somebody had some quantitative data on it. Patients being coerced to have C-sections that they don't need so that doctors can charge for the surgery. It's something that's really worth investigating more. There's systemic corruption, so a large fraction of the payments that women are going to be getting from the JSY program actually are prepaid to nurses and doctors and cleaning staff in the form of illegal payments. The ASHAs, these are the village health workers who accompany the women to the hospitals, are used to enforce these payments. So the ASHA needs the nurse to sign off in order to get her own incentive payment. And so she has strong pressure on her to say to the family, hey, you need to pay this doctor, you need to pay this nurse. We met a lot of people who are not formally employed by the hospital, but can actually pay their bills through these illegal payments. And this is an interesting sort of, on the one hand, the hospitals are understaffed. On the other hand, if people are paying for supposedly free services and they're getting paid to be in this hospital, like, people come in and fill these gaps. And then, JSY has a long list of consumables and drugs that are supposed to be provided for free. By and large, that's not happening. People get all of their drugs or consumables from outside the hospital. They pay for it themselves. There's just abysmal hygiene in these hospitals. The sheets are not changed between patients. And I think, as with much of sanitation in India, we can really look towards caste-based hierarchies to understand why the hospitals are just as filthy as they are. So there's a strict hierarchy that dictates who in the hospital can do what sort of cleaning work. If the person from the caste that cleans blood or feces is not there that day, or just having a bad day or not feeling well, no one else is going to do that work, and it's going to stay until the person from that particular caste will come and take care of it. And both from a hygiene perspective and from a human perspective, I think it's worth talking about the pervasive casteism and abuse that the sweepers who are employed in the hospital face every day. So, not being able to eat with the other hospital staff, not being able to use the chairs in the hospital. These are insults that don't motivate a person to want to do his or her job on a daily basis. So let's turn then to this sort of third reason that the hospitals are probably not improving health in Uttar Pradesh very much. So we saw that low birth weight was an enormous problem, and that one place that the hospitals have an opportunity to come in and help improve health would be by paying more attention to low birth weight newborns. Unfortunately, the little bit of attention that they do get is more on the side of medicine. So increasingly there are baby warmers in the district hospitals. There's more oxygen. I know you guys probably saw the news stories about Gorakhpur and the lack of oxygen in the children's hospital. I've been surprised over the years to see any oxygen appear at all in these maternity hospitals. And increasingly, they're hooking babies up and giving them some drugs. But that will probably happen for a day or two at a time. There's very little focus on care and on feeding. So, there are great ways of keeping a low birth weight newborn alive. They're very low tech. So there's this technique called kangaroo mother care, where a woman can keep her baby on her chest, and that keeps the baby the right temperature. It encourages breastfeeding. It's not taught. Women should be taught proper hygiene for low birth weight babies, and then should be supported in breastfeeding. And this breastfeeding in particular, I think, is something that would be a great opportunity. Moms could be taught what goes on with a low birth weight baby. Often they don't have the energy to suckle in the way that other babies do. They need to be spoon fed, so the mom should be pumping and spoon feeding or paladai feeding. If it's not working out after the mom has tried to breastfeed, how could we hygienically bottle feed the baby? That would be something that mom could be taught. And unfortunately, parents are almost entirely aware of the risks of hypothermia for low birth weight infants. So, they have some sense because they watch the baby that breastfeeding is tough, but hypothermia is a thing that very, very few people are aware of. To wrap up here, let's say, what might help these hospitals perform better? So it would be fantastic to have reliable administrative data on health outcomes in hospitals. But as I mentioned before, nurses and doctors have strong incentives to report a particular set of outcomes. And so I think it's very unlikely that we're going to get reliable administrative data anytime soon. For that reason, it would be great to have more regular independent survey data. So this would involve sending out surveyors to the homes of people who had recently had babies and tried to understand what happened in the hospital, what sort of care did they get. It would be great if there were somebody at health ministry and down level to make hygiene monitoring visits. But I get concerned that, in the couple cases where I've seen this happen in Uttar Pradesh, it involves a lot of pressure on the cleaners for a couple days, and then it goes away. So it would have to be sort of unannounced, which I think is unlikely to happen. And it wouldn't address sort of the broader caste-based discrimination that's behind this. I really wish I had ideas for what sorts of trainings or programs would change the hearts and minds of people who grew up in a society that was just sort of steeped in caste hierarchy. I don't know who would be the right person to think about what those programs or trainings would look like. And then here's one that I think might be the most promising. We could have counselors in the hospitals whose job it was to teach parents to care for low birth weight babies and to promote breastfeeding. The medical staff don't think this is their job. They think their job is to administer injections and use machines and things like that. Somebody who was particularly supposed to do the sort of counseling and human interaction side. But when others aren't doing their job and the culture of the hospital is such, I'm not sure why we would expect these counselors to start counseling. And so now to sort of wrap up from a bigger perspective, in addition to all of the stuff that's going on in the hospitals, why might it be hard to reduce neonatal mortality in Uttar Pradesh more broadly? We could be focusing on improving maternal health and health during pregnancy rather than on hospitals. Unfortunately, one government tool for doing that, the ICDS, works really quite poorly in Uttar Pradesh. We could talk about the details of sort of the food contracts that have governed ICDS in Uttar Pradesh for a long time. What little food does get to the villages is rarely given to pregnant women. Often people don't want to eat it. And then there's the idea of maternity entitlement. So in 2013, maybe 2014, the National Food Security Act legislated 6,000 rupees of maternity benefits for every pregnant and lactating woman. Most recently, the government has announced that it plans to give this cash transfer only for the first birth, and it hasn't been rolled out in much of the country. Some of Anjani's work actually looks at how this program, even in the pilot districts, is extremely delayed. So I think it would be, a wonderful place to start and to ramp up, but the government has already announced that it doesn't plan on really relying much on this tool. And then, even if you were able to deliver more public awareness about maternal nutrition or more food or cash to a household, you would face the problem that sort of causes poor maternal nutrition, which is intra-household discrimination against women. There's not a good reason to think that women in these households would be able to get the benefits of the cash or of the extra food. And then I think just to return to this point of how it would be really wonderful to have credible data from Uttar Pradesh, particularly on neonatal mortality, also on stillbirth. It's something that I haven't talked a lot about, but the data on stillbirth are even worse than the data on neonatal mortality. And from a human perspective, stillbirth is almost as bad for a mother to go through as her baby dying. And so that's a health indicator that we could have a lot higher quality measures on and on a much more regular basis. So thank you very much for your time.